Yeah, just my take on things. My answer to number 2. Guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Those cognitive distortions decrease until they cease. Let's go. Guided discovery. Identifying, challenging your beliefs.
All right, everybody. Well, I tell you what, if you are a regular to this podcast, you're thinking, this is not a familiar voice to me, because typically the person who initiates this podcast is Dr. Dan Weisman. But Dan is off today, and he's given my colleague and I, Kate Molino, an opportunity to lead the show a little bit. And I am super grateful for the opportunity to be here and to kind of lead this, because a lifelong friend and a trusted colleague and a shipmate of mine is going to be the person that we're interviewing today. I'm going to introduce Dr. Pamela Wall. Pam, I was reflecting this morning when I was preparing for the podcast that you and I met September 1st, 2001, while we were both in uniform. It was a rather fateful day. And I'd ask, could you just take us a few moments just to kind of give us your elevator speech in terms of your experiences professionally and academically that makes you particularly valuable to the listenership of this podcast?
So when Sean said shipmate, that's S-H-I-P, shipmate. So I just wanted to clarify that. So, hey, it's nice to be here. Thanks, Sean. So I am a psychiatric nurse practitioner. I was also a clinical nurse specialist. So I'm one of those old ones. And when Sean said we met on September in 2001, that means we're very old. We're older than the dirt. So my experience is that I have been a nurse since 1996. I joined the Navy about the same time. And I've done most of my career as a psychiatric nurse, a psychiatric CNS, and an NP, both in the military and in the civilian sector. So spent 20 years in the Navy as a nurse corps officer. And then when I retired, I have been working in a variety of civilian settings. I've been a professor in 4 different universities. The first one was a place called Uniformed Services University of Health Sciences. That is the military university. I started the psych nurse practitioner program there. Oh boy, 2008. It's been a while. And then I was at Duke University. I started the psych nurse practitioner program there, and that was in 2016 or 2017. I was also at University of New Hampshire, and now I'm at Rosalind Franklin. I'm an associate professor there. Some of the other fun stuff that I've done was I worked at the United States Peace Corps as a international health coordinator. So I was the only prescriber for all of the Peace Corps in 61 countries that the volunteers served in until that pesky little virus changed our international landscape. So that's just a little bit about me, and I think I'm going to be done there.
Cool. Pam, thinking about the gigs, right? What was the best gig and what was the worst gig?
I think they're all good and bad. I think it depends upon the people that you work with and the things that you like and you don't like. So I think I've always liked them in that I like the patients that I'm working with and a lot of the people that I work with. And really what I hate is the admin, the charting, all that icky stuff that's in the background. That's the stuff that I really don't like. In academia, I really love the students. I really love watching the aha moments that occur. You know, you have to be 3 steps and 5 days ahead of every single one of the students. So you yourself learn a lot about clinical practice. So it's all good and it all has its drawbacks. So I can't say that there's one thing I loved and one thing I didn't love.
Yeah, Pam, I'm so happy to have you here today and have the opportunity to pick your brain. You've had such an amazing career. You know, one thing I'm wondering if you could tell us about is your experience providing psychotherapy in your role with the Navy, with, veterans or active duty service members, and how you honed your skills, the types of psychotherapy you provided. Give us a picture.
So That's a big question. So I'm going to start off with my favorite is I love CBT. So I actually started doing CBT with Sean way back in the early 2000s. We had a cognitive behavioral group, and we learned a lot. We learned the basics there, and I think I hate to say this, but the best practitioner is the one that does it on themselves every day. And so through a series of learning it there, and then I actually learned from the experts themselves at Penn, my education at Penn, we had a course there on CBT from the Beck Institute. So I learned a lot of strategies from them. And so I don't think there's a single session that happens in my patients where I'm not implementing some kind of cognitive or behavioral strategy. And so that's a big chunk of what I do. There's a little bit of gestalt here, a little bit of the miracle question here. And I also do a lot of functional medicine stuff. I know it's not therapy, but I really focus a lot on exercise and proper nutrition because I really think decreasing neuroinflammation in our patient population is a good strategy to decrease some of our negative outcomes in our patient population.
Pam,
For all of the questions.
yeah. Pam, you got your PhD at Penn, and if I remember correctly, your focus was a lot on TBI and sleep. Am I correct?
Yes.
How does that practically translate to your patient care on a daily basis?
So I always look at there are things that I start off with. So I look at the medical, the substance, and those are the things that I'm going to try to focus on first. And we get rid of that and we peel that away. And the next thing I always look at and focus on is the sleep disorder. And if we have impaired sleep, that's going to affect anxiety. It's going to affect depression. And so it's really important to strategize on decreasing the impact of sleep deprivation in our patient population. It could be a number of different things that are going on. It could be patients having problems falling asleep, staying asleep. It could be as related to pain. It could be related to a medical condition. So that's really one thing that I try to focus when I'm managing those patients. It could be from sleep apnea. And sleep apnea, and I just did a podcast with NEI, and one of the things that I look at in my patient population, especially those with TBI, and people don't really think about this, is that patients with a lot of repetitive mild brain injuries can have sleep apnea, even though they don't fit the normal profile. And so if I can't figure out what's going on, I will send them for polysomnography, especially with patients who have mild traumatic brain injuries. And they do have sleep apnea, which again, repairing that sleep problem is definitely going to help those mental health outcomes.
Yeah, this makes me wonder. In my clinical practice, I also work a lot with folks who have brain injuries of various types. And I'd be curious to know, Pam, how do you, modify or maybe adapt your psychotherapeutic approach or strategies for folks who have TBIs?
So I think number one is environmental. When people have brain injuries, especially when they're more in the post-acute phases, I want to definitely attune my environment to them. So you want to soften the lights. You want to make sure that you're not yelling or screaming at them. Of course, you wouldn't want to do that anyway, but decreasing the environmental sensory load on them. The psychotherapy, you can do just about anything with them, but you have to make sure that they are cognitively capable of managing. So, if they're having a lot of headaches or a lot of pain, CBT is probably not the best approach for them. You might want to wait until a lot of the pain issues have been resolved and focus more on a behavioral management strategy more than on the cognitive strategies.
Awesome. Pam, I'm thinking I'm going to take you back to your time in uniform. There is a subset of the community of individuals listening to this podcast who are going to be women, and they're considering military service. And I'm wondering if you might be able just to share some thoughts with the community about what it was like being a female naval officer, psychiatric mental health nurse practitioner, working in what was presumably a male-dominated field.
interesting and loaded question. So most of my career, if you think about the Navy, most of your career as a nurse is probably going to be located in what's called an MTF, or military treatment facility. And it is going to be heavily saturated with other women, especially in the nurse corps. But there are some certain billets that one can now go to. It wasn't always that way when I was in the military, but you can now get into billets where, such as in the Marine Corps, infantry billets, where it is heavily saturated with men. And I, I took Sean's billet with one of the Marine divisions. And when I went there, I was the first female nurse with one of the Marine divisions. And I think there was maybe 70 or 80 women. And I don't know how many people are in a division, tens of thousands of male Marines. And when people ask me about that particular 2.5 years, I define it as formative. They expect a certain they expect certain things from you. And I think that I had to work a little bit harder as one of the first women who was living in that lane. I definitely took care to make sure that my physical readiness was always up to standards, if not above standards. So every day we would go out and PT with our group. I had a service dog, and not my own personal service dog, but she worked with the unit that I work with, and she was out there PTing with us as well. And it can be very uncomfortable sometimes when they don't assume that you're a woman. And here's what I mean by that. The Marines, they look at your collars. They look for shiny things on your collars, because that means whether or not they have to salute you. And they see something shiny on your collar and they salute you, and they're not expecting at that time to see a woman. And so almost 99 times out of 100, I would get saluted and they would say, "Good morning, sir." And then they would look up at my face. And then there was this shocked moment and this moment of embarrassment when they realize it's a girl. So it was kind of funny, kind of awkward, but they approached it with, "I'm not expecting this." Now, here's a funny moment, and this is probably going to embarrass people that, I don't know, I don't care. My husband is a former Marine. He was a Marine, reconnaissance Marine, so he was special forces, and he is now my husband. And when you're an officer, you would generally, the general's wife would send out emails to the officers' wives. My husband would get emails from the general's wife that were titled "Dear Ladies." So they just hadn't moved to this spectrum of, now there's women in an infantry billet. So it was just very, very, I would say awkward, I think is the word I would use. I was never sexually harassed by anybody, because they weren't stupid enough to do that. Because I was a field grade officer. Nobody was dumb enough to do that. But I can't say that that's the same experience for every woman who served in and around men in the military.
Thank you, Pam. I'm just thinking about how, a lot of our audience is American, but we actually have a global audience. And so this is really, I think, insightful in terms of, how does this world operate? And I'm wondering if you can maybe say a little bit about, what inspired you to join the military, and then how does it work in terms of becoming a provider as an officer?
So when I was considering joining the military, I was working as medical assistant in a West Side Chicago emergency room, and I loved the idea of continuing. I went through nursing school, and I was considering whether or not I wanted to continue working in the emergency department, which is very exciting, but it's very emotionally draining. And so we had a recruiter come through school, and one of the things that she said was, "We will pay for your graduate education," which was very exciting for me. And I think that was probably one of the things that drew me to the military. And the second thing is they said, "You can go anywhere you want to." And they flew us to San Diego, and they took us on a nice recruiting trip. And of course, I was sold. And so I think one of the best experiences that I had in the military was the opportunity to get not just one graduate degree, but two. And so the military paid for two Ivy League degrees, which I would have never been able to attain on my own. And I think that was probably the best experience that I ever had. I think part of nursing is not only growing as a nurse, but diversifying yourself. And it doesn't matter how or where you diversify yourself, but finding a population that you love and going there. I fell into mental health nursing literally because I thought I was going to be Johnny Trauma, and I ended up as a mental health nurse practitioner. So the military did a great job of allowing me to go with where I loved going, and they paid for it.
Pam, you and I have cared for probably more Marines than we can count on all the hands that are probably in our immediate vicinity. I want to ask you a question. We know, both of us, that Marines, when they deploy, they develop a rule book. And that rule book is a set of rules they use to survive a rather challenging situation and circumstance. I like to think that a seasoned advanced practice psychiatric mental health nurse, in or out of the military, also has developed a rule book. Can you share a few thoughts about what's in your rule book, being mindful that a pretty good chunk of our listenership are students that are running through a psych nurse practitioner program as we're speaking?
That's a great question. So I think one of the things that I haven't told you about myself is that I am a legal nurse consultant. And I was also trained by a forensic psychiatrist. So a lot of how I think and what I do is from a legal and forensic perspective. And so my rule book is largely driven by that lens. And so what I recommend is having a process that you do all day, every day, and stay with it. And so what I tell myself and my students is always know what the scope and standards are that you operate under. And so the APNA has it, know it, get to know it, because you can and will be held against it or for it and with it, right? So that's the national standard. So I know that book by heart, and it drives your state practice acts and how you will be licensed and credentialed, what you can do, what you can't do. I don't deviate from it, right? So I think that there's some people who kind of go out on the fringes and do some things that maybe not are within our scope of practice. I don't ever do that. And so anything that I think is not within my scope of practice, I move it to another provider that's within their scope of practice. I stick with the clinical practice guidelines and the FDA recommendations. And if it's not FDA recommended for something, I always document everything. I document all my decisions. I document everything that happens in the care. And so I'm pretty good about documenting everything. And then what I do every day before I get ready for clinic is I prepare ahead of time. And so I will pull up my records every day, spend about an hour, and I go through all my notes and I refresh my memory with what happened last time. What did we do? What's the outcomes? What am I thinking about, and what do I want to do in this session? And so I prepare ahead of time, because I always go back to me being that floor nurse. I could not start my day without cleaning my nursing station. And so that's how I practice. I clean my nursing station, I get ready. And so I prepare myself every day for my practice by getting to know my patients all over again. So that's my rule book.
Nice.
I love that. Clean your station.
I think we found the title for our
I
podcast.
think so. So Pam, as an educator yourself, I'm curious to know, what are some trends that you're seeing in psych and P education that maybe you feel excited about, and what are some trends that you feel maybe not so excited or cautious about?
I don't think there's, well, let's start with the not so excited about, and I'm probably going to get thrown under the bus for this, but I think there's a lot of programs out there that are popping up that I would say, not a lot, a few, that I'm concerned about because there's not a lot of hands-on between professors and students. The students are left to their own devices to learn on their own. There's not a lot of interaction between the students and the professors. And I am very concerned about that type of interaction and those types of programs. And I'm just going to leave it at that. I am very excited about all of the new technology that's out there. I know that a lot of people don't like the technology, but it's kind of cool. The stuff that we can do in simulation, the stuff that we can do. And I'm sorry if you can hear that. I have a new puppy and she's howling right now. Okay. All of the new technology that we have available to us, the simulations. And again, I've said this before, functional medicine, I'm a really big proponent of it. I think we just need to go back to basics in our care. We need to go back to being nurses. All this bougie stuff that's out there, let's just go back to sleep, diet, exercise, being healthy, and really focus on therapy, right? Therapy, nothing is going to work that we do without a good healthy dose of therapy. It doesn't work. So I think, if you're treating depression, you have to have therapy. If you're treating anxiety, you have to have therapy. You can't just throw a pill, and you definitely can't treat trauma without therapy. In fact, I think medications, and I get thrown under the bus for this. So putting medications for trauma is like putting a Band-Aid on a bullet hole. They need therapy. That's the only thing that's going to help people with trauma, really bad trauma. So we just need to go back to the basics. That's what I'm excited for. And I think that we're going in the right direction.
Cool. Pam, I'm going to finish up with our last question for the day. And this question, let me set it up. Each and every one of us have a experience with a patient that once it happened, we went, oh my God, it actually worked, right? And it actually kind of emboldens us to realize that, wow, there is something special about psychotherapy that I didn't really consider. Can you de-identify and share the story with us to let us know that point in time where you realized, I'm an advanced practice nurse, but you know what? I'm also a really good psychotherapist.
Gosh. Oh my gosh. I gotta think about that one for a minute. This was probably when I was at Second Marine Division, and I had this Marine that I was working with, and I was thinking about doing CBT with him. And this is my fault. I had some really negative assumptions about this person, and I thought it's never going to click. This person's never going to get CBT. And I had your office, and you had the CBT stuff on the wall, and I was drawing all this stuff on the wall, and I was doing CBT. And he got it. He got it. And he started making all these positive changes in his life. And I sat back and I went, okay, first of all, I'm an idiot for making these assumptions about him. And that's on me. And then I'm just like, I got to stop making assumptions about people because that makes me a poo-poo head. And second of all, he got it. I know how to do this and he got it. And so I thought that was a great story.
That's awesome. That is absolutely awesome. Pam, I'm going to press pause. Kate, final thoughts for you, my friend.
I guess Pam, going back to cleaning your station and so on, if there is one piece of advice that you could give to, Psych NP students who will be graduating soon in this context in which we're all living in 2026, what would it be?
Keep it simple.
Excellent. Friends, for those of you listening, I'll share with you, if you jump into higher education, if you jump into academia, if you jump into advanced practice nursing, it will be difficult for you not to come across the name Dr. Pam Wall. She's incredibly well published. You'll see her at national conferences. When you do, I encourage you to approach her and make her feel uncomfortable and tell her about all the cool things that you've read, because she really does love that. And Pam, I want to thank you very much. This is a perfect point for our 25th anniversary as friends and colleagues. So thank you so much for your time.
Thanks for having me, Sean. Thanks for having me, Kate.
Too much salt like this, too much seasoning. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. Guided discovery, identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease. Yeah, guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease.